When a patient gets admitted to hospital as an emergency, it's very important they're able to answer 4 simple questions. The first is, what is wrong with me? Or at least, what are you trying to exclude? The second is, what have we agreed that we're going to do this morning, this afternoon and tomorrow to get me better? The third is, what do I need to achieve to be able to get out of hospital? And that's the clinical criteria for discharge. And the fourth is the expected date of discharge. So the ideal way to set an expected date of discharge is to assume that a patient's recovery will be ideal, that there will be no unnecessary waiting. The clinical criteria for discharge is what the patient needs to achieve to be able to leave hospital. The first consultant contact can be the most appropriate time to set an expected date of discharge and clinical criteria for discharge, and it should be done in discussion with the patient and their carers where necessary. So we create an expectation of what should be happening in an ideal recovery pathway.
By using the principles of the red to green, we have reviewed the expected date of discharge on a daily basis. So anything that is a barrier to discharge or something that makes a discharge more complex will affect the expected date of discharge, and we can adjust that. Sometimes we're able to adjust it forwards.
We can learn a lot from how surgeons have implemented enhanced recovery for elective care. The Enhanced Recovery Programme sets objectives each and every day to progress a patient's care towards their expected date of discharge and what they need to achieve on discharge. Exactly the same principles can be set within emergency care as well. To set a clinical criteria for discharge, you may well need to use 1 or 2 physiological parameters such as the temperature, the blood pressure, the pulse, the oxygen saturation.
With a surgical type of procedure, it is slightly easier, I feel, in that once the surgery or the intervention has been carried out, the consultant can say when certain things have happened, when the bleeding stopped, if the bruising has subsided, those kind of things, we can predict when somebody is likely to be discharged. However, it then still becomes a team effort. We rely very heavily on our junior doctors to be aware of what the clinical criteria for discharge are. So if they're looking at infection and inflammatory markers, it's more up to a junior doctor to keep those monitored, and they're the sort of things we would expect on a daily basis.
But crucially importantly, particularly for older people with frailty, there will need to be a function element. How far that person needs to be able to walk, with or without a frame, to be able to manage at home.
I think it's very difficult with older, frail people who have lots of comorbidities to make it a distinct pathway, because the norm for somebody in their 80s and 90s is not the norm for somebody in their 30s and 40s. However, we're very fortunate in orthopaedics in that we have our care of the elderly physician who works as an orthogeriatrician, and she will set those clinical criteria for the older person on an individual basis, really. So if they have chronic kidney disease, she will give us the parameters for their blood results to be their norm, which then allow us to continue with our expected date of discharge.
The most important thing about implementing expected date of discharge and clinical criteria for discharge is to stress that it's a clinical instrument. It is not a managerial instrument. What the clinicians are doing are setting what the expectation is for that patient's recovery in hospital. It's about how we help patients to get better, faster and safer, and to reduce any unnecessary waiting in their journey.